Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with bilateral occluding, soft, wet, sticky earwax and dead skin. They actually are suffering from a condition called otitis externa, which is an umbrella term given to an infection or inflammation or even dry skin even of the ear canal. And in this particular case, the entrance of the ear is quite inflamed, it's a bit swollen, which makes it very difficult for me to insert the microsuction tube. So this is a standard Zollner suction tube here that I'm using. And as you can see, it only just fits within the ear canal. There's very little leeway or room for manoeuvre. What makes this procedure even a bit more difficult, other than the narrow ear and inflamed ear canal, is the consistency of this wax and dead skin and debris. It's very sticky and glutinous, which can make it quite difficult to suction. However, I'm managing slowly but surely to progress deeper in the ear, and you can see I've got a big plug that's just about to come out. And this plug was stuck right up against the patient's eardrum in a region called the inferior recess, where there's a little trench, a little basin just at the floor of the eardrum. And I managed to lift it out, but as you can see, because of their narrow ear canal entrance, this plug of wax and skin, it's getting trapped. It's a lot larger than the entrance of the ear, so I'm just going to wriggle this through. And there we are, I'm slowly but surely manipulating this out of the ear. It's very sticky. So I've got the main plug out, and already the patient's symptoms is completely alleviated. They can see their eardrums, the sound that enters the ear can travel towards the eardrum and vibrate the eardrum. And these vibrations are then transmitted through three little bones in the ear, and they're collectively known as the ossicles. The first bone is called the hammer bone. Medically, it's known as the malleus. The second bone is most commonly known as the anvil, and the medical name is the incus. And the third and final bone, which is the smallest bone in the body, is commonly referred to as the stirrup bone, and medically it's known as the stapes. And the stapes bone is adjoined, it's connected to the organ of hearing called the cochlea, and it looks like a snail. And the cochlea is full of fluid and tens of thousands of microscopic sensory hair cells. And in response to sound, so when the sound hits the eardrum vibrates. The vibrations are transmitted through the three ossicles, the three bones, and the last bone, the stapes, when that vibrates, it causes the fluid within the organ of hearing to travel in waves. And the fluid movement, these waves travel over these little sensory hair cells, which cause the hair cells themselves to shear side to side. And that searing motion creates an electrical impulse within the hair cell. And that electrical impulse is then transported from the hair cell to the part of the brain that processes sound, so the auditory cortex via the hearing nerve, and we process that as sound. So there's four pathways. The hearing pathway is made up of four components. The outer ear, so the job of the outer ear, which is what, as an audiologist and a clinical ear care specialist, I'm busy cleaning and removing to allow sound to enter the outer ear. So that's the outer ear. Then you've got the middle ear, and then you've got the inner ear, the organ of hearing, and then finally you've got the brain itself. So we call that the central processing department of our hearing. It's quite commonly overlooked. Quite often you can get people with absolutely normal ear canals, eardrums and organ of hearing, but they still struggle to hear, and that's because although the brain's receiving the sound from the ear, it's not able to process it as efficiently and effectively as it should, and that can itself lead to a condition called central auditory processing disorder. And it's something that I feel and fear that is it should be more commonly diagnosed. So we're making good leeway here, and although the sound can travel towards the eardrum, the sound does reflect off the ear canal. So I kind of go back on myself slightly earlier saying the patient can hear back to normal. They certainly can hear much, much better. But some of this debris around the edge of the ear canal will absorb some of the sound energy travelling through. So I'm just trying to remove as much as I can. Now, we've got to be sensible. And I think in this ear, actually, without taking any silly risk, I managed to remove all the skin. I think in the right ear, there's a little bit left on the eardrum. But when I first started removing earwax from people's ears, there was no way that I would be able to remove as much debris as I am now able to. So it does take a lot of years of practice and experience. And it's something that I do stress to any specialist that is trained by myself. Sometimes less is more. Don't try to be silly. Always work within your limitations. The main criteria of removing earwax is the patient comes to you in order to hear better. So as long as they can leave hearing better, which may mean there's a bit of debris left, a bit of wax here and there. And a bit of wax is actually not bad for us. Wax is a healthy secretion. I've been doing loads of radio rounds in the last week, and one of the main questions asked by the interviewer is the function, the purpose of having earwax. So my response was that earwax is a naturally healthy substance, and it has 3 primary health benefits. The first health benefit is earwax is slightly acidic in nature, and the acidity of earwax helps to repel insects, believe it or not. And it also helps to inhibit bacterial and fungal growth. Also, earwax is greasy and oily, and that helps to hydrate and protect the skin, moisturise the skin that lines the ear canal, prevent it from drying and cracking. And the third benefit is earwax is the ear's mechanism to clean itself. So any foreign particles, dust, dirt, pollen that enter the ear, they stick to the wax. And in the majority of our ears, so to 90 to 95%, I would say, earwax naturally migrates out of the ear, it comes out by itself. And as it does, it expels any dust or dirt that is collected. So earwax is good for us, hence why our ears secrete the earwax. But of course, excessive earwax to the point where it obstructs the sound travelling through is not good. So I'm just using the fine end suction probe here. You can see there's some dead skin here that I'm just peeling away posteriorly. I did put some drops in there just to soften this skin, and I managed to remove that slithery skin off the eardrum. So the eardrum's fully visible, but there's just a bit of debris anteriorly, so the front part of the ear canal here. And I'm just, as I said, I'm just using the fine end suction probe here. I'm just gently trying to peel this away. Sometimes this won't come away, no matter how hard you try, and you just, at that stage, leave it. The patient's already happy. Removing all this debris, the patient still, this is a chronic condition for the patient, so they will be back. They come back twice a year, actually. So no matter how much you clean an ear, quite often it's a short-term benefit. The patient will develop the issues again. If you suffer from earwax and you're what I call a waxy person, inverted commas, it's very likely that it will return. So there's just a bit of residual oil there that I just suctioned up. And again, you can just probably saw how narrow the ear canal was in that little frame when I was coming out with the suction probe. So I'm just going to the roof of the ear canal here. I'm just peeling the skin downwards. So I did get a lot more out in this ear than I thought I would, so I was quite pleased. There we are. I think I'm content with that. So I'm just going to mop up just near the entrance some of the excess oil and a bit of skin there. So again, that gives you a good perspective of how narrow and also how bendy the ear canal is. The ear canal does really bend. You can see you're going to the right and then back to the left, and that's the patient's eardrum. So that's their left ear complete, and they were really, really happy. That was the worst ear of the two. So this is the right side, and again, the entrance is really, really narrow and somewhat inflamed. So I'm using the standard Zollner suction probe in the first instance, and that's because with the fine end suction probe, it's just not going to be powerful enough for this, and it will get blocked up very easily because of the consistency of the wax and the debris in the skin. I think it did also get blocked with the full Zollner suction probe. And I think I'm going to apply some olive oil spray in a moment. So you can see that ear canal entrance is completely shut. Just using the endoscope to stretch the ear open. And I'm just going back in. So we've had a few people interested in the iClearScope, the endoscope, who are audiologists, I should add, but they've never used an endoscope, and we do stress that they're gonna to use an endoscope. It's a difficult skill. Once you've mastered it, there's really nothing better than an endoscope when removing earwax, because the view it provides you, it's just unparalleled compared to even to the Waxscope, the other device that I developed. So I've got another YouTube channel, Clearwax. If you type in Clearwax, the link is actually in the description. I think it's the second link. You can see the Waxscope in action, and the Waxscope differs somewhat in that it provides more of a microscope view. It's very magnified and focused, but the view, it's not. You don't get the same panoramic wide field of view. With an endoscope, it's like you're inside the ear and you can see all around you. But to use an endoscope, it's probably not probably. It's a lot more skillful to learn. But as I said, once you've learned it, it's unbelievable. It's changed my clinical practice, being able to use an endoscope. But it does require highly specialised training, and even for myself, when I went to train, I trained with an ENT surgeon. But we just get a few people that sometimes they don't want to do the training, they just want to buy the kit, and we do stress them. It's just going to be a waste of money, and quite often they do come back to us and say, oh, we're not able to use it. And we did say, look, we did review about this. And the reason why I say this is because in the UK, I think earwax removal is seen as a very trivial thing. It's one of the discussions I had with a radio interviewer just the other day, BBC Radio Newcastle. Some of it may have not been aired, but the interviewer is very very careful with his ears, because he's had problems in the past, and he would never trust anyone who's not qualified to enter his ear. And quite rightly so. They're very sensitive organs, and they're very precious, and things can go wrong very easily. And I was talking kind of more off air, and he was saying that who doesn't do earwax in the UK, and I says, in the UK, it's a free-for-all. Anyone can. There's no legislation about who can or who can't. It's like Botox injections here, and aesthetics. Literally anyone can do it, as long as you don't lie about your qualifications. You're not breaking the law. And the interviewer was quite gobsmacked. So you could actually book in with someone who's not actually a qualified person or healthcare professional in ears. And I said, yeah, it's quite common in the UK. I know of some big organisations that are training their admin staff, literally 2 days training, who've never ever looked in the ear. They've got no clinical experience, no experience with the ear. The admin staff that work within a hearing centre, and I'm shocked that they're just getting trained within 2 days, using really poor technology, should I add as well. And the interviewer was quite shocked to learn this, and says, well, isn't there anything that can be done, because they wouldn't themselves be comfortable seeing someone with such limited experience and background, with no clinical experience or healthcare experience. And it's unfortunate, there's nothing, my hands are tied in the UK, there's nothing that I myself can do. It's similar to the world of Botox. I know it's been for years. I know someone many moons ago who's a doctor, and they were wanting to get involved in aesthetics, and I was shocked when they told me that literally anyone could. There are people out there just offering the service, and it's such a specialised area. When I was looking through some of the theoretical work and practical work, they went on a proper course, you see, medical course to do all this. So I was looking at all the syllabus, and it was really high. It was really, really in depth, and I thought, how can people just do this without this training? Because there's so many things that can go wrong. And I think it was a course of about a year on top of their medical degree. So it's just the way they are. So I think the moral of the story is if you are having your earwax removed in the UK, I don't know how it is around the world, but do your due diligence. I wouldn't feel comfortable, even imagine if I wasn't an audiologist, I knew nothing about ears, but I wouldn't feel comfortable knowing that if I was taking my mum, for example, to have her ears cleaned, by someone that really hasn't had the necessary skill and experience, and they're not from an audiological background or a nursing background or a medical background or an ENT background who basically were just trained just a few days training. I mean, I went on a 4-year degree to learn about the ears. And of course, not everything I learned on the degree is relevant to earwax removal. Earwax removal is more than that. It's also the hand-eye coordination, but you do need to know about the ear. It's critical. Someone's ear, something goes wrong, you should understand the possible things that can go wrong and the different pathologies, and you can't just learn that in a day. It's kind of disrespectful to those professionals that have spent years training and learning their art. Now, that doesn't mean if you can be a great audiologist, it doesn't mean that you'll be great at earwax removal. And vice versa, you might be great at earwax removal, but you may not be a great audiologist. But it's fundamental to have the background knowledge. And I was talking to an ENT about this, and they were slightly miffed by some of the practices that are going on, but that's where we are, unfortunately. So yeah, do your due diligence. Make sure when you book in, and I'm telling you because I know things can go wrong and have gone wrong, and I've seen a lot of things, and I just think it's important to the public to know that to do your research first. Find out who's doing the procedure, but their background, their experience. Are they from a clinical background? How much training have they had? What technique are they using? These are all relevant things. So going back to this procedure, you can see we've cleared the ear now. The eardrum is fully visible. It's just this bit of skin posteriorly now. I tried my best to remove this, and this is one of the things I was saying before. Sometimes less is more, and I was trying to, and at this point it's not uncomfortable for the patient, but it will be in a moment. And at that stage, you just quick while shut. I think it was at this stage, the patient just felt it just a bit uncomfortable. So we just left that, and that should naturally migrate away from the eardrum now. But I hope you enjoyed that video, guys, and you're all taking care of yourselves. Do stay tuned. I've got loads more videos to upload. Speak soon. Bye.